Good evening, everybody. I'm Dr. Ndlovu, and I will be speaking to you today about the quality of recovery post-surgery in this SASA Journal session. The outline of my presentation is as follows. So I will be beginning with the introduction. I will look at ERAS, then I'll also move on to look at the quality of recovery tools, quality of recovery 15 score. Then I will look at the evidence behind the quality of recovery 15 score, and then I will end with the conclusion. So to start up my presentation, I have taken a quote from an article by Stark et al. In Anesthesiology, published in 2013, and it reads as follows. Recovery after surgery and anesthesia is a complex process dependent on patient, surgical, and anesthetic characteristics, as well as the presence of any of numerous adverse sequelae. So when we look at the enhanced recovery after surgery pathway, it has many interventions. The interventions are instituted in the preoperative phase, in the intraoperative phase, and in the postoperative phase. This recovery pathway was instituted or begun by Professor Kellett, and it was initially intended for patients presenting for colorectal surgery. What was his intention of instituting this particular intervention in the perioperative period? The main intention was to fast-track these patients. And we know that when patients are fast-tracked in the perioperative setting, it helps us to reduce postoperative complications. The other benefits of the enhanced recovery after surgery is that these interventions reduce the stress response and also reduce hospital costs by reducing hospital stay. Enhanced recovery after surgery has become a buzzword in many of the different surgical specialties. It has been adopted in neurology, in orthopedics, and also just a few years ago in obstetrics, where they have instituted enhanced recovery after cesarean section. It's also becoming a buzzword in pediatric surgery, where various interventions to expedite the recovery of the pediatric patient have become instituted. While this model is amazing, it is also can be time-consuming and requires participation from a multidisciplinary team. And in our particular setup, we have not been completely able to institute all the measures of this pathway. However, certain aspects of this pathway have begun to be instituted and have produced some good results. Though this model is also very good, it tends to be more centered around what healthcare practitioners prescribe or intend to do for the patient, but it is not patient-centered. It also does not speak to the quality of recovery, though the patients are expedited in terms of their recovery and discharged, but it does not say anything about the quality of that recovery, and hence the presentation today. What is the quality of recovery? So there are different tools that have been instituted in order to assess for the quality of recovery. And as you can see in front of you, from the 1970s, there was a tool called the post-anesthesia recovery score. And in the early 2000s, various scoring systems started coming up, such as PSR, the 24-hour FAQ, and of interest, the QOR 40, which has been widely cited. And in 2013, the QOR 40 was refined to the QOR 15. These various scoring tools look at different aspects, and in particular, paying attention to the QOR 40, they looked at the patient's functional status, the psychological state of the patient in terms of their emotions, the cognition, and the patient's symptomatology in the perioperative period. All these parameters filtered through to the QOR 15, which I will be talking about in this presentation. So in an article by Stark et al. Called Development and Psychometric Evaluation of a Post-Operative Quality of Recovery Score, the QOR-15, they went into great depth into how they arrived at this particular scoring system, what were the things they included, and why they included these parameters in the assessment of the quality of recovery. The aspects that they looked at were the patient's pain experience, the physical comfort, physical independence, psychological support, and emotional support. They also then went on to devise a patient questionnaire. The questionnaire is divided into two parts, namely Part A and Part B. The questionnaire has been made in such a way that it addresses the patient's experience in the last 24 hours post-surgery. Different components of the questionnaire have been examined in the patient experience. For example, is the patient able to breathe easily? Is the patient able to feed? How does the patient move? Are they dependent on other people for their personal hygiene? Are they getting sufficient support from the nurses and the doctors? Are they able to contact their loved ones? Do they feel a sense of control and well-being while they're in hospital? There is a scoring system between 0 and 10, 0 being none of the time, and then 10 being all of the time. Then in Part B, also examined in the last 24 hours post-surgery, they explore the patient's pain experience. They ask about the presence or absence of nausea and vomiting, and they also further explore the patient's emotional state by asking about symptoms of anxiety and depression. The difference in the scoring system is that there is a flip. Instead of 0 to 10, in this case, it says 10 to 0, where 10 is none of the time and 0 is all of the time. Once the questionnaire has been done, the scores are totaled up and the following deductions can be made. A patient who scores more than 135 is deemed to have an excellent quality of recovery score. A patient who scores less than 135, but more than or equal to 122 is deemed to have a good quality of recovery score. A patient who scores less than 121, but more than or equal to 90 has a moderate quality of recovery score. A patient who scores less than 90 is deemed to have a poor quality of recovery score, and a patient who scores poorly should be investigated to find out why the patient has scored such low scores, because these patients may also have complications that need to be attended to. So the quality of recovery 15 score was then subjected to various tests in order to find out how accurate it is and how close it is and how effective it is to the QOR 40, which had been around for quite some time. So the QOR 40 had 40 questions, and it explored all the different aspects of the patient experience in terms of the physical and emotional state and how the patient is coping in the hospital environment. However, it was time consuming. So hence the need to contract it to 15 items. But in the process of contracting it, there was a concern that they might lose the accuracy and the efficacy of this particular scoring system. So then they had to subject the quality of recovery 15 tool to various measures or tests. And these tests include validity, tests of reliability, responsiveness, and utility, which I will go into depth in the subsequent slides. So starting with validity. So construct validity relates to what is being tested, what is being assessed. So validity speaks to the fact that does this particular test do exactly what it says? Under construct validity, we look at two aspects: convergent validity and discriminant validity. With convergent validity is when one uses different tools to assess a certain outcome. In this case, quality of recovery tools of a different, from a different source are used to assess the quality of recovery in a given patient. And if there is convergent validity, it means a similar signal should be produced or they should be coherent in assessing for quality of recovery in a particular patient. Then there's discriminant validity. The way I'd explain this is that, for example, if a patient was to be asked if they're depressed, that being the first question, and then the second question, and if the patient answers yes, and on the second question, they then asked, are they on top of the world? Do they feel they have control in life? Are they living their best life? And then they answer no. That is discriminant validity because it is in keeping with the patient's experience. So you wouldn't expect a patient who's depressed to feel that they are living their best life. So the negative response should correlate with the other response that has been given. So we call that discriminant validity. So you wouldn't expect a patient to say they are depressed, but they feel that they're in absolute control and on top of the world. So that is discriminant validity. And when you are able to detect that negative experience in correlation with another question, looking at the similar aspect, it shows us that this particular scoring system is doing what it says it is doing. The next one we look at is reliability. So there are three aspects that we look at: internal consistency, split half reliability, test-retest reliability. So internal consistency says that the items that are being examined in the questionnaire, how consistent are they? Are they going in the same line? Are they asking things in a similar way? And there are ways of assessing internal consistency. So there are statistical methods of doing this. For example, the Cronbach's alpha coefficient assesses for internal consistency in these items. And if it's more than 0.7, there is internal consistency. And when Stark et al. Subjected the QOR15 to tests of internal consistency, they found a Cronbach's alpha of more than 0.7. The next form of reliability testing is the split half reliability. And what split half reliability does is that the items that are in the questionnaire are separated into two segments. And if you remember from the QOR15, it has two parts. There's part A and part B. So for example, when we're exploring the patient's emotional experience, we explore the patient's emotional experience using different questions in part A and also in part B. If there is split half reliability, you expect that the response you get in part A in terms of the emotional experience should be coherent with the response that you get in part B. It is more effective to assess the patient's experience in the two different segments as opposed to accessing the patient's experience in one part of the questionnaire. And because when you have assessed the patient's experience in both parts and the signal is consistent, then you can say you have split half reliability. The next form of reliability testing is test-retest reliability. What happens in this form of reliability is that you get the participants to take the questionnaire at the beginning, they go through it. After 1 hour or 30 minutes, you get them to do the same questionnaire and the signal should be the same. And if you get a similar signal after getting the participants to take that particular test twice, it tells you there is test-retest reliability. Moving on to responsiveness. So responsiveness is also very important. what it relates to is the ability to detect a clinically significant difference. And for this, we use the Cohen's d coefficient. And when the Cohen's d coefficient is more than 0.8, it is a strong indicator of clinical responsiveness. I'll give you an example. Let's say, for example, you gave this patient this questionnaire before they go for the operation and they had no pain. They were coming in for an elective procedure, but it so happens that the pain management was not great. And then when you give them the questionnaire post-op, you would expect that the patient is going to be in pain, like severe pain, especially if the pain was not managed properly and you suspect it was not managed properly. If that is the case, then you would expect the questionnaire to be able to detect this difference, and there should be a clinically significant difference from the time the patient filled in the questionnaire at the beginning pre-op and when they filled the questionnaire post-op. And if the questionnaire is able to pick up that difference, we say that it is responsive. The last form of testing that they subjected the QR-15 is utility. Utility speaks to the patient recruitment rate, successful completion rate, and we know that the QR-15 is only 15 items, so the success completion rate is much better than when you have 40 items that are in the questionnaire. And then the time taken to complete the questionnaire was found to be 2.6 minutes. So that is much less than what was before in previous questionnaires. And in order to assess utility, I also conducted a little research of my own. And I took the QOR-15 patient survey as shown by Stark et al. And I asked somebody to help me to translate it into Xhosa, as our population is predominantly Xhosa speaking. I wanted to see if it had utility in our patient group. So I used similar scoring systems as quoted in the article, and I gave patients this particular survey. So what I found is the average time that it took for them to finish it was about 3.5 minutes. And the reason why they probably took longer was because when you have to translate some of these terms, you tend to use more words in African languages as compared to when you're relating to English, where you can just write a few words and people will be able to understand. And sometimes I found that the patients needed a little bit more time to go through the questionnaire and assimilate what exactly is being asked. So hence it took them slightly longer to go through the questionnaire. But overall, they all completed it in under 15 minutes, and they found it quite easy to complete. And the questions were very direct and easy to understand. So when it comes to evidence, so we've talked about how the QR-15 is responsive, it's been validated, it's reliable, and it has utility. But can you then initiate it or start using it in your practice? You would need evidence. And the highest form of evidence we know are systematic reviews. They are the gold standard when it comes to research, systematic reviews and meta-analysis. But how does one arrive at conducting a systematic review or a meta-analysis? So there is a process, and it's important for us to understand the process before we can properly critically appraise an article. So the first thing is to formulate a research question and assess what is, or establish what is your eligibility criteria. After you formulated a research question, you then want to have a prior hypothesis to explain heterogeneity. After that, you want to conduct a search, and you're going to look at different medical databases, and it's advisable to get a librarian on board because they have more experience when it comes to searching for articles and for evidence. After you've found out all the different articles, you want to screen the titles and look at the abstracts. Then after you've sifted all through these titles and abstracts, you end up with the studies that you are more interested in, and then you're going to go through the full text of these articles and try and include them in your systematic review. After you've included those articles, you are going to then look at the risk of bias, and if there's bias, you further exclude the articles that have got bias. After that, then that might give you a platform to perform meta-analysis based on those studies. So the systematic review that I looked at concerning the QOR 15 is an article that was published in the British Journal of Anesthesia in June 2022, that is last month. And it's entitled Measurement of Quality of Recovery After Surgery Using the 15-Item Quality of Recovery Scale, a Systematic Review and Meta-Analysis by Miles et al. So after looking at the abstract and reading it, this is what I got from the authors. The conclusion was the QOR 15 is a valid, reliable, and responsive patient-centered outcome metric in surgical patients. It is highly acceptable to both patients and clinicians. This is such a profound statement. And when you reach such a conclusion, you're like, wow, I just want to include this QOR 15 in my practice. But as we know from research, that things are not always what they seem. Sometimes when you pick up a juicy tomato, it looks very nice on the outside, but once you cut it, you may be surprised to see that it's full of worms. And sometimes research is like that. Things look good from the surface, but when you look deeper, you start seeing a lot of irregularities. I'm not saying that this article is full of irregularities, but it's important for us to understand that you never take an article from face value. It's important for you to scrutinize the methodology, look at the discussion, and more importantly, to look at the protocol. So for this systematic review, I went on to Open Science, where the authors say that in the article, their protocol could be found. And systematic reviews often have a protocol available online that you can go through and assess what exactly they intended to do and how they intended to go about the systematic review and what were the shortcomings of that systematic review. So in order to assess for the credibility of a systematic review, there is a certain process that needs to be followed. And the 7 points that are of note are noted in the book by Guyot, JAMA Evidence, and that's the template I will be using to assess this particular systematic review on the QOR 15 scoring tool. So the first question is, did the review explicitly address a sensible clinical question? And they did that. This review did exactly that. They looked and they were very clear about their clinical question. They wanted to look at the efficacy and how this QOR 15 is being used and its applicability and across different studies. Was the search for relevant studies exhaustive? This is a little bit unclear from their protocol. It was not very clear if it was exhaustive, but they did different search strategies using mesh terms, using PubMed. There was a certain effort to look at studies. Was the risk of bias of the primary studies assessed? That's also important. I will touch a little bit more on this in subsequent slides. Did the review address possible explanations of between study differences and in results? They did that as well. Did the review present results that are ready for clinical application? I would say an emphatic yes. Were selection and assessments of studies reproducible? that was a little bit difficult to reproduce based on their protocol? And lastly, did the review address confidence in effect estimates? That they did manage to do as well. And I will show you in subsequent slides. So they compiled a forest plot from the different studies. And in this particular forest plot, they were looking at the retest reliability of the 15-item quality recovery scale. And there was a clear signal that this particular scale has good retest reliability, as it is more than 0.8, and most of the studies lined up clearly, or most of them. I mean, only 2 were kind of a bit of like, in fact, 1 was an outlier, but majority tended to line up quite nicely. Then they also looked at the responsiveness of the scale, and it was over 0.8, which showed that it was responsive. They also looked at complications and the utility of the QRR15 in detecting for complications. Generally, what they said is that it had a moderate effect in assessing or trying to detect for complications. And you can see from this forest plot that they only included 4 studies. The reason being that some of the studies that they included, and they had 1,000 studies that they managed to pick up, but eventually they had about 26 studies that they included in the systematic review, and only 4 of them indicated issues to do with complications. So the signal was not very strong, but they could kind of speak to complications based on this quality of recovery scale. So though they did discover or actually come up with positive aspects of this quality of recovery scale from the systematic review, there were issues. Firstly, heterogeneity was an issue because they had different studies. They had randomized controlled trials, they had observational studies, they also had cross-sectional studies that were in this particular, that were included in the systematic review. And because there were different studies, they had difficulty ruling out bias because the tool that they used to rule out bias was the ACCESS tool. And they state clearly in the discussion that the ACCESS tool is not made to rule out bias in observational studies, and it was only suited for cross-sectional studies. There was also a problem that some of the studies did not address the things that they were examining. For example, complications, they only had 4 studies that looked at that. Other studies had missing data. They did not look at responsiveness. Some did not look at reliability and other aspects. So pulling all these studies together, there was something missing, and hence when they did the forest plot, some studies were left out, some studies were included. Another issue with this systematic review was the timing of the questionnaire. It's not very clear as to when this questionnaire was distributed. Was it in the preoperative phase? Was it 24 hours after the patients had been operated, or 72 hours? So there was a study where patients were given the questionnaire 72 hours. And we know that if a patient is to tell you about the experience, 24 hours as compared to 72 hours is definitely going to be different. We know that patients post-op, they tend to be groggy, and you expect that the quality of recovery score is going to be low. And if you assess the quality of recovery score after 3 days, it will probably be good. So if you were conducting a study of the quality of recovery in a particular institution, and you did the quality of recovery at 3 days and somebody else did it at 24 hours, definitely there's going to be a difference between the scores that you'll obtain. And then if you pull these studies together, you may not be able to make a good assessment because the tool is being used at different times. Another important thing to note as well is that when they were doing the forest plot, I noticed that the first author of this article, a number of his previous articles were included in the forest plots. And colleagues that he had worked with in designing the QR15 in 2013, their articles as well were also included. In fact, the first author, 10 of his works were part of this study. So that does raise eyebrows, and that might be a source of bias because he was involved in the making of this tool, and a lot of his studies as well have been included in this systematic review. So that may cast a certain level of doubt. However, coming back home, there was an article that was published towards the end of last year in Analgesia and Anesthesia and Analgesia 2021, August, called Quality of Recovery Following Orthopedic Surgery in Patients at an Academic Hospital in South Africa. This study was conducted at Helen Joseph Hospital, and they used the Quality of Recovery 15 scale to assess the patient's experience. The patients that they enrolled into the study were patients who had orthopedic surgery, and they had knee and ankle surgeries. And what they found is that post-operatively, the patients were in excruciating pain, and the authors made a recommendation that the peripheral nerve blocks need to be used during the perioperative setting, and they need to be more aggressive in terms of addressing the patient's pain experience. This type of experience, what they experienced, I don't think it's unique to them, because most of the time in our setup, patients who come in for lower limb surgery tend to receive a spinal anesthetic. And normally what happens after they receive the spinal, they're not in pain. Even post-op, they are not in pain. When they get to the ward, the nursing sisters see the patients, and the patients are absolutely comfortable. But as the spinal begins to wear off, the pain that they experience, the pain actually begins to become worse, and the patients can end up suffering a lot from severe pain. So it's very important to be identify these patients who may be at risk and to be aggressive in terms of pain management. And it's interesting that the Quality of Recovery scale was able to help these authors or doctors identify the problems in their system and address them and improve the patient experience. So there are advantages to the QR15 score. It has a moderate effect in detecting for complications. It identifies areas of improvement in the patient care pathway. It can reduce the hospital stay. It can reduce hospital expenditure, and to a certain extent, actually reduce litigation, because litigations normally arise from patients being unhappy about the level of care they've received. Sometimes it's not because they were not attended to, but because there was misunderstanding or communication breakdown between the doctor, the nurses, and the patient. And patients can become very upset, and then they may go the path of litigation. So instituting this Quality of Recovery scale tool can actually reduce litigation, because you'll be able to pick up complications earlier, be able to address the patient's concerns earlier, and will be able to reduce hospital stay and hence litigation. Though it is good, it does have limitations. Those limitations relate to the fact that if a patient has got a psychiatric disturbance, it may be difficult to assess their quality of recovery. In the pediatric population, the scoring system may not be applicable. For example, there are certain items where children may not be able to relate. So for the pediatric population, there may be a need to devise a different type of scoring system that will speak to this population. Patients who have got drug dependence and alcohol abuse and they are intoxicated, it's difficult to institute this Quality of Recovery score in that group of patients. Patients who are deaf, patients who have got a language barrier, and patients who have poor comprehension, it becomes difficult to institute this Quality of Recovery 15 score in those patients. So in conclusion, I'd like to say that recovery from a surgical procedure is more than physiological reconstitution. Our assessment of the quality of recovery should be based on a patient-centered approach. Quality of recovery scales can be used as tools to identify areas for improvement in the perioperative patient care. And as I'm ending this presentation, I'm reminded of the words of Prof. Mer from Joburg Gen, who say that working in a poor resourced setting does not mean poor care. And we know, for instance, we are in the Eastern Cape, in a resource-constrained environment. However, I can safely say that we are privileged to a certain extent compared to other parts of Africa. We probably have more access to equipment. We've got a whole array of drugs, and we should be able, and we are able, to deliver better care to our patients with what we have. And instituting the quality of recovery 15 score could be the first step towards that, to identify problems in the patient's experience in the perioperative setting and addressing those things. And it's the little things that make a difference in the patient outcomes. So before we aim for bigger things, let us start small. A simple questionnaire could be a turning point in your hospital, and it could change the outcomes of many patients, save your hospital lots of money, and save the Department of Health in the Eastern Cape from several cases of litigation. Thank you so much for your time. And these are my references.